Hey team, thanks for joining me today for another CHOT training minute. Today we're going to be covering part 3 in our Deprescribing series. So the first the first session, we talked about overprescribing and polypharmacy. We defined those and talked about how those affect our clients and their medications. We talked about deprescribing, we defined it, and we talked about what it is, why we do it. And then in part 2, we talked about barriers to deprescribing for physicians, for families and patients, and for us. Today, we're going to cover communication strategies for deprescribing, how to have those conversations, and what that looks like. So let's jump right into it. First of all, we're going to talk about some general strategies. The first general strategy is to use a shared decision-making model guided by the patient's goals of care. What that means is we want to bring the patient, the family, whoever's making that decision about the goals of care into the conversation so that we can talk about deprescribing and talk about medications and why we would continue them or why we would suggest that they be deprescribed. If we get buy-in from the patient and the family, then that makes that deprescribing conversation easier. The next thing is to weigh expected benefits versus burdens. So talk about what the benefits of those medications are, what they're doing for the patient, why they were prescribed to begin with, and then talk about if there are burdens. We need to weigh those benefits to the burdens, and the burdens could be side effects. It could be part of our polypharmacy conversation and pill burden. And we talked about pill burden being a complex regimen that makes it hard for the patient, the caregiver, to follow that regimen. So we need to weigh those things against one another so we can figure out and explain to the patient, talk to the patient or the caregiver about what the benefit versus burden is. Consider a gradual dose taper, or a time trial. And this is a good method and a good strategy, especially when talking about, in my experience, when talking about certain medications like Namenda and Aricept. So medications that this patient may have been taking for a long time for their Alzheimer's or dementia. And once we get to end-stage dementia, end-stage Alzheimer's, we know that those medications have almost little or no benefit to the patient's prognosis, to the patient's diagnosis. Those are for cognitive reasons that we give those medications. And most of the time when we get to a truly end-stage Alzheimer's or dementia patient, those cognitive things aren't being affected by the medication. But because they've been taking them so long, one of the strategies that we use a lot of times is to taper that dose so that the family and the patient, the caregiver, get an idea of, hey, we're going to just gradually taper this down, or we're going to do a time trial. Many times I'll have the conversation of taking a week off, right? We're going to put this medication aside for a week, and we'll reevaluate in a week or a few days, however long that time period is that the physician wants to do the time trial for, and we'll reevaluate after that time period to see if there's been any kind of change. With knowing in the background that we can always start that medication back up if we're seeing some benefit for the medication. Be patient and establish trust. This is another big one. We know that when we first come in, they don't know us, we don't know them. It's just like any other kind of relationship. We have to establish rapport and trust with them so that they know, hey, these people are the experts and they know what they're talking about. So we have to give ourselves some time, right? We have to give ourselves some time to establish that trust. We don't always have that kind of time, but when we do, that's one of the strategies we should be using. And then focus on what hospice provides, not what we're taking away, but what the benefit is going to be in the medications, the therapies that we're going to use in lieu of some of these medications that are being deprescribed. And that always comes back to the goals of care, and that's why it's important that the patient, the family, the caregiver have bought into those goals of care, and we're real clear that we have a team formed and they are part of that team, so that they've bought in on what those goals are. All goes back to care planning and establishing that care plan as well. So, what are some signals to open discussion? What are some signals that the caregiver or the patient is open to having a discussion about deprescribing? Well, some kind of green lights that you might see. I'm so tired of taking all this medication. I've heard this countless times from patients, even when I first walk in the door to do an admission. I'm so tired of taking, look at all these medications. I'm tired of taking this. That's a green light to have the conversation of, okay, I understand. I am looking at all these medications. I can't imagine having to manage trying to take all these. Let's look at these one at a time, and medication by medication, to see what we might be able to set to the side, or what maybe you don't need anymore that's not benefiting you. What we can do to alleviate the symptoms of your disease, versus these medications that might really be more for curative purposes. And so if they come at you and say, I'm so tired of taking all this medication, that should be a green light to you. Another green light is, I've heard before, mom's having a harder time swallowing her pills. So the first thing we need to assess for, obviously, is signs and symptoms of dysphagia. And if there are swallowing issues, what they're trying to tell you is, hey, I've seen some things. Mom's choking on this. She's having a hard time swallowing it, or she's keeping it in her mouth. Maybe they're pocketing medications. That's a green light to have that discussion. And again, part of your nursing assessment of, are they having dysphagia, and are we needing to address that as well with either different forms of other medications or deprescribing medications that aren't beneficial anymore. Another one is, I don't like the way that pill makes me feel after I take it. Like, I take this medication, but I've always had these leg cramps. With statins, that is a big side effect that patients see and experience. So if a patient says to you they don't like to take a pill or a certain medication because they don't like the way it makes them feel after they take it, that's a green light to have the deprescribing conversation and say, okay, we have this medication. You don't like the way it makes you feel. Benefits versus burdens, right? So we go back to that benefit versus burden, and have that conversation about deprescribing if it's appropriate. And then finally, it doesn't seem like this medication is helping with mom's memory anymore. So again, with Namenda, Aricept, some of those medications we use in end-stage Alzheimer's and end-stage dementia, those medications are for cognitive ability. So in end-stage patients, the caregivers for sure start to see that those medications aren't really doing what they used to do, and a lot of times they'll just come out and say it to you. So again, another green light to have that conversation. Do we need to do a dose taper or a time trial and see if we can set that medication for a while and see if it's really truly having any kind of benefit? And then finding the words, like, what do we say? How do we say it to patients? It can be a delicate conversation with patients and families, but how to find the words, we use clinical data if it's available. Like we've said before in previous trainings, a lot of these medications, there isn't a lot of clinical data. They don't do a lot of clinical studies on end stage or dying patients, unfortunately, with medications. So there's just not a lot of data on some of this stuff. But if we have it, we want to use it, and we will redirect always back to those goals of care. So what is the goal of care? Well, if we're talking about Namenda or Aricept, something like that, that is really a long-term benefit kind of drug that's used in earlier stages, not end stage dementia or Alzheimer's, then we want to look at the goals of care. Well, the goals have shifted from retaining cognitive function to comfort care, right, and symptom management. So we want to redirect to that. Focus on palliative aspects of the regimen. Are the medications relieving the symptoms? So are the medications that the patient's on right now, when we look at a medication list, when we pull those medications out and put them on the dining room table, right, and we're looking at them with the family and the patient, are those medications helping us to achieve the goal of palliation of symptoms? And so we look at each one of those and we determine that, and we have that discussion with the patient and family, and we talk about it. Like, our goals are to control the symptoms of the disease, and this particular medication doesn't do that. So how about we set that to the side? How about we do a dose taper or a time trial if it needs to be done? A lot of times families will just say, like, or the patient will say, I just don't want to take these things anymore. If it's not going to benefit me, I'd rather not put all these pills in my stomach. I'd rather put something like a bite of ice cream that I might enjoy in my stomach. So focus on those palliative aspects. And then finally, consider safety. So a good example of this is with hypertension medications. As folks decline and get closer to death, one of the natural processes is that blood pressure may actually start to decline and fall and drop. So if that patient is still being given their hypertension medications, what are we doing? Well, we're driving that blood pressure even further down. Where if we put those medications to the side, that patient actually might be normotensive at that point, and be even more alert, and have a higher quality of life, right? So we need to pay attention to the medications that we're giving that do certain things and affect people as they decline, and those things actually start to take care of themselves, like hypertension. That's all I've got for today. Next time we'll start to cover some specific medications and classes of medications. And I hope you guys have a great day. Thanks for watching. We'll talk to you later.